I'd be curious to ask you, Sean, actually, on that same vein, not knowing what it looks like. I mean, so to go way back to the original questions of what residency looks like, in the ER, we also, from an internal medicine perspective, got, over the course of 3 or 4 years, depending on where you trained, about a month of true internal medicine. Now, you have very little clinic work, and then you have every other subspecialties work, and then, of course, year on year, you have more time in the emergency department. But during your intern year or your second year or both, you'll get a month, in general, of true hospital internal medicine, plus whatever rotations, more so, actually, in med school than you do in residency. So, to be honest, at this level, at a big, busy shop where we're at now, I'd be speculating still to some extent to know what your actual shift and day looks like in detail. So admitting that, I guess my question in regards to, I should also preface this with one other thing. I will admit, at least in this system now that I'm working in, I have far less trouble or conflict or uncomfortable moments with any internal medicine doctor in this group, and have for years. I have a lot of respect in it, and don't really have difficulty communicating, conversing, talking with, chatting with, admitting to, or discharging on the recommendation of an internal medicine doctor at our shop. I have far more difficulty with any and every subspecialty consultation that I'll make than an internal medicine doctor. It so far outweighs the likelihood of trouble and conflict coming on that I don't have any trouble with the IM doctors at all.
Well, and they're the ones we converse with the most.
Maybe that helps. And it may help, but it certainly also says it's
culture in that regard.
We do, I'd say. I have zero qualms in comparison to thinking about consulting a specialist most days, consulting a hospitalist for an admission request. That said, I have found over the last couple of years that there are not infrequent occasions where I think it may be beneficial, and that's the question to you. Is it detrimental to your day? Is it a pain in the ass, or is it more helpful and effective? I've found more cases where I think I, myself, am a bit on the fence about this patient needing to stay at all versus a 24-hour OBS versus a true inpatient admission. Something doesn't feel quite right. Something doesn't look quite right. But I'm not, in our particular system, savvy enough to know what the follow-up may look like, how safe this is to pull off in our community, what are the chances this is going to fall through the cracks kind of thing, and it's just going to lead to another ER visit tomorrow. On patients that I'm on the fence at the end of their ER workup, there's nothing else I can do, and I'm thinking, I am debating whether this needs to stick around. I have kind of coined my own term, I'm sure it's out there, that I'd like to consult a hospitalist just like I would consult a surgeon. What do you make of this CT read? Is that surgical or not? Is it an overcall by radiology? Calling the internal medicine doctor or texting sometimes and saying, I'm a little uncomfortable about sending this patient home. Here's what I have and here's why I'm nervous. But what do you make of that? Or even calling on the phone and saying, hey, honestly, this is a consult call for internal medicine, which I'm sure, just like an ER doc, you don't get a lot of consults other than clear them for surgery, please. From us, it's not really a typical consult call. You don't call the internal medicine doctor for a consult generally. But I have found that occasionally over the last few years, it's been exceptionally helpful to say, I'm not sure what to make of this, and I think it's up IM's alley, and you'll see more of this. How's this likely to play out, and what do you make of this, and would you watch this overnight? I've had really positive responses, even on busy days, from most of the hospitalist crew. It doesn't happen all that often. But do you think, your own perspective and your cohort, that is a infrequent and valid use of your time and our time? Or do you tend to find those cases ones where you go, man, they should know that, it's totally okay, it's not a big deal, I'm wasting my time on that, or I'm not coming down to see that? Or how do you feel about that kind of being consulted as an IM doc for an ER doc who's just not sure where it's going because I've got all the info I'm going to get now, and it may not be enough to be comfortable?
How much do you miss rounding from the Wayback Machine being in residency?
Well, I chose emergency medicine, so I'd say it's fairly obvious that I don't miss it.
So to get to your question, and I really, really appreciate this question. I think my cohort and I, by and large, enjoy the consult question. It gives us an opportunity to problem solve alongside of you. And I think what everybody at this round seated session here have a good sense of is what the inpatient hospital resources can offer. I think we have a better sense of just what that flow looks like over what time it occurs.
Yeah.
And then most importantly, what the discharge in this case looks like. This conversation is much easier to have when we have a robust outpatient primary care space
Yeah.
to receive these patients back, or very little wait time in a system to get patients in to see specialty providers.
Right.
Outpatient providers are up against it from a reimbursement perspective, the demographics of our aging population, how we are doing more and more with managing chronic illness that has exacerbations as opposed to acute illnesses that have a discrete period of treatment time resolution. So they are up against it.
Yeah.
And I did that job for 2 years and I did not re-up. No
Yeah.
chance. There's too much to it. So all that to say, I think that the consult question in the ER is one our cohort especially would love to see more of.
Oh, interesting.
I think I speak for pretty much everybody in the group when I would say if you're unsure or you want that extra bit of just gravitas towards a discharge or an admission, and it's not the assumption that they should be discharged with a consult note just to give that backup, but let's problem solve alongside you. And I think that our group would love to do more of that. Nationally, I suspect that's probably true as well. And I do wonder if this kind of brings into the conversation the idea of what are your metrics. I think I've heard things like throughput time in the ER, things like a consult might delay things an hour, but it might actually save the patient a hospitalization, or it may help to arrange more expedited outpatient triage. A number of systems are experimenting with hospital at home programs and what that looks like. And, ER consults with the hospitalist are a way to parlay the case into that sort of environment setting. We don't have that at our institution right now. And I'm not sure if it's going to be there for a long time and reimbursed the way that systems want. But regardless, I think this conversation is top of mind for our group. And I think by and large, we would love to be consulted as much as possible.
That's fascinating. I think the reason that's been so well accepted on my end too is because I'm not pitching it as an admission. I think a lot of our docs that get nervous, not just our docs. I've worked all over the country, locums, big shops, small shops. There's a good spectrum of emergency medicine physicians, younger or older, who are get nervous about the patient's disposition, and then therefore nervous about the interaction with a hospitalist, and then therefore immediately put the presentation forward as not I'm not sure, which is okay to say. I'm
Absolutely.
never going to have all the answers most of the time. I'm not going to have all the answers in the ER, versus saying, hey, I think this patient needs an admission, and here's my thoughts on why, when what they're thinking is, could you give me your thoughts on this? It very much matters how you word things.
It's the same thing we
you
do
got
when
a
we
busy
call
hospital
cardiology,
service,
when
you
we
pitch
call
it as an
neurosurgery.
admission.
It's the same thing.
The same thing,
we
right?
ask our specialists.
Yeah,
for.
exactly. I think
Is the expectation appropriate with, if I'm consulting you on somebody, I'm not sure if they're safe to go home, that you come and examine the patient? Is that part of a consult, or
Yes.
is okay?
Yes.
And that's okay. You guys are okay with that? That's not a bother to you? Or is it maybe better because you can come down and save kind of a pointless OBS admission that maybe is not needed? I mean, is that what you guys would prefer?
I think there are systems where the rounding reimbursement staffing model might not set one up to be very encouraged to come down to the ER and do those examinations. But I at least for me, when I have that, I get that call from Adam saying, hey, this is kind of a consult for me. I want to talk about this case. I think what we hear is, how do we help a colleague? I hope at least, how do we help a colleague? How do we help this patient? And how do we make a decision together? And all of us want to work, I believe all of us want to work in a shop where there's more communication across specialties, more communication across disciplines, there's more mutual respect. And getting together at the bedside or, in one of the pods down in the emergency department with you guys and sitting down and talking about stuff, popping a bubbly together or whatever, beverage du jour we're having, I think is great. And I think we should come down and examine the patient if there's a consult question. And let's be clear, that's an encounter for us. We can, be part of the medical decision-making process. We can submit our expertise where appropriate to payers, et cetera. So it's not like we're not incentivized to be a part of that process. And I think that should include an examination, a review of the objective data, and a conversation with the patient.
That's good to know. I feel like that's not something that is super standard, and maybe maybe some of these patients where I'm trying to sell an admission that is not super clear, maybe the better practice would be to be like, hey, do you mind just coming in and seeing this patient? I'm not really sure they're safe to go home. I'd love your opinion on this. And knowing that kind of the expectations that you come down and see them, because that's something we deal with some specialists is they look at the information, they don't come and examine the patient. And I'm like, you really need to come and poke on their abdomen because this is still concerning. I know their CAT scan looks fine.
Yeah.
But laying hands on the patient and actually physically seeing them, knowing that that's part of the consult, I think is really helpful. Because I think that's our fear is like, are you just going to look at this totally normal workup and be like, they're okay to go home? At least that's my worry sometimes. But knowing that, if you're going to come examine them and we can both agree and come to a decision where we think they can go home with some follow-up, that maybe that saves some admissions too.
I would even go one step further. And one thing for the internal medicine doc and one thing for the ER department to hear. I think I would even go as far as cutting grace to the internal medicine doctor that, in all honesty, a conversation on a rare occasion is enough. There are times where I literally have thought, I don't need you to come lay eyes on this patient. I need you to hear this story and think about this. And it would be a bonus if you came down. So I would even go as far as saying that's okay and not even necessary every single time, even though most. I would also go as far as saying, you hit a little soapbox, but I'll keep it super short. Anytime someone in the ER, in my opinion, whether you're an attending, a nurse practitioner, a PA, whatever your practice level is, if you're an employee of the emergency department who works on furthering the disposition of a patient that we have seen, and you are going to use it, unless you're absolutely joking, use the terms, I got to sell this admission, I think you ought to think twice about your own process that you've taken so far. Did you get all the data that you possibly could? Did you think it through in a logical manner? Have you done what you can do to the extent of your abilities and capabilities in the emergency department before you tried to move this forward? It's exactly the same as hearing someone say, well, I rolled the dimer dice and I lost. I hate that. Now, some of that's biased. My research area was in PEs and DVTs. I'm biased because I'm really biased for a good reason. There's a finite niche of patient population where that particular test applies, and you really ought to try and make yourself expert on knowing the data on where that test applies, when you're about to order it inappropriately, and when it's appropriate. So when I hear, I rolled the dimer dice, I immediately get a little hot-headed and go, did you use your education and your brain before you painted yourself into whatever corner you're trying to paint yourself into? Same thing when you say, I got to sell this admission. If you, as an ER provider, an adequate, intelligent ER provider, feels that they're going to have to sell something to someone else, I don't think you've done your best, or you would give yourself credit for saying this isn't a sales pitch, or you'd have the gumption to say this doesn't need to come in. That's just my thoughts.
No, I think you're right. I think selling it is bad verbiage.
We say it,
right. No, I think you're right about that for sure. I wanted to jump into about kind of what your workflow and what your workday looks like, because I don't know, as an EM physician, maybe you have a better idea, but as a PA, I did a couple months of, internal medicine rotation in PA school. So I have a little bit of an idea, but, not in this environment. So I think it's helpful for us to kind of know what your day looks like. I know what 20 ER patients looks like. I don't know what 20 admissions looks like.
Our location here breaks the roles up into rounding physicians and admitting physicians. So for the purposes of maybe this conversation, I'll focus on the admitting physician role. And our admitting providers come in, like you guys, at a very early hour, and we're inheriting any admissions that came in effectively time 0 minus 1 hour from the overnight team, so they had time to wrap up their work, make sure everybody's tucked in, and passed off to the day team. Because at present, we're running about 60 to 80 admissions in a 24-hour period upstairs. So those people have to have time to distribute, the overnight half to all the teams, make sure that the lists are more or less balanced, everyone's accounted for. And then during the daytime, the admitting provider is receiving what you guys send, making sure the triage decision is right, making sure the specialists that need to be involved are involved, and really setting up the next person for success. That's really the role of the admitting provider is, do we have the stability we need? Do we have the wheels in motion for the next person to walk in and say, tweak here, tweak there, but by and large, I can take this baton and run with it. So that role typically is very easy to do in the early hours of the morning, and it becomes exceptionally harder as the day progresses. Our peak hours of admissions are generally between 3 and 7 p.m.
Okay.
I will routinely be on a rounding team, look at the admission list and check on the admission provider and see that they've gotten maybe 6 to 8 admissions by noon. But in the final 6 hours of their shift, they'll get 20 to 25.
Okay.
So that really increases. Now, our institution, other institutions are, I think, working very hard to staff accordingly. One of our colleagues, Danny, who works nights, will say that, every restaurant in the world has it figured out that you got to have more hostesses, more bartenders, more bussers, more chefs during the lunch and dinner hours than you do with breakfast. So how can a hospital not have that same idea? And so we've done, I think, a decent job of staffing up swing shifts, et cetera, to achieve that. I think the hardest part about the admitting shift is that on average, and some people do this to a greater degree or lesser degree, just the exchanges with the emergency department or outside providers looking to do direct admissions or the ICU looking to downgrade's the wrong word, to transition care from the ICU to the general medicine floor, can go between 80 and 150 pages a day. So they are constantly being bombarded. Of course, when you feel that phone vibrating in your pocket when you're in with the patient, you don't know if it's someone you admitted earlier is decompensating. You don't know if it's the ICU trying to give you someone. You know if it's the doc line trying to call you for a transfer, right? So their channels of input are so numerous that at least at our institution, we've instituted a admission support administrative member that helps to field a lot of that. Check insurance is someone that we take just because we have a Kaiser team that takes care of their own people, not for any other reason. And that they're not taken care of by a concierge private group. So I think that the hardest part of that job, besides the volume and how it crescendos towards the back end of the day, is just the volume of pages that come in. Now, some institutions have solved this by doing things like a round robin admission situation where your rounding teams will take admission 1, then 2, then 3, and it sort of drips through each. Our institution has set up a process where we have geographic rounding, which makes that challenged, because if I am the doctor that's on the East Tower on a certain floor and there's an admission page for a patient to come in, and then I admit that patient, but they end up on a different floor than I was doing them for, it adds a handoff. It decreases continuity of care, which is the entire intent of the geographic multidisciplinary rounding situation that we have at our group. So the ability to handle admissions and address admissions, I think, is very much dictated not only by the volume of what you guys see, but then by the bed tower situation that we are living with, as well as the other inputs to the admission, doc line transfers, outside hospital transfers in our case, as we call them, and then the ICU transitions of care.
And is the admitting doctor kind of delegating the actual seeing of the patients then to other hospitalists, or is that always the case, or are they certain hours are they coming and doing it all themselves?
So if we take the example of our daytime doctor, it's 6 a.m. to 6 p.m. and they are effectively eating as much as they can until they cry uncle. And then if it's, hey, this is becoming like a patient safety issue with the volume, I'm passing them off. And we have sort of built-in release valves for that with a 10 a.m. to 10 p.m. swing shift and then a 2 p.m. to 2 a.m. swing shifts. Okay. But the expectation is that, and based on the numbers we talked about a moment ago, each of those docs is going to be seeing anywhere from 8 to 12 in a shift. Admissions, pure new admissions.
Okay. And that's, I mean, in each of those admissions, you're, doing the full charting on, you're looking at everything, examining the patient, potentially involving the specialist.
That's right. Well, what we have to do to complete our encounter based on the forces that is, of course, the subjective history, the background history, family, social, past medical, past surgical, allergies, exam, labs, plus what you guys have gotten, plus what we add on, synthesis, and then calling folks in full admission order set.
Okay.
That's right.
Okay.
And then ideally telling the patient what we're actually doing for them.
Right. That's good to know. I think, so I mean, can you speak a little bit to kind of like the workflow then for the admitting hospitalist? I mean, so you're getting phone calls from transfers coming from outside facilities, you're getting patients moving from the ICU to a general floor, and then on top of that, you're getting 12 ER consults that you need to actually do all the stuff on, basically. Is that kind of right?
That's right. So I guess the discrete unit to talk about is, do I have to be involved in this person's care for a transfer out of the ER and arrival from an outside? And so that starts with that initial communication page. There's follow-up communication as needed. there is then probably a very truncated chart review looking at the most recent outpatient or hospital encounters, where we get a sense of where's this patient been going, what's been their trajectory. Does this look like just more of the chronic illness over again, a new thing I'm going to have to work up, or maybe both at the same time? And then from there, it's actually seeing that patient, calling specialists accordingly afterwards, and then probably placing orders at that time.
Okay.
So that's kind of the work process I would describe.
Okay. What are some of the admissions that are the most frustrating for you guys as IM docs? I would guess that it's probably the ones that we're stuck with where they bring in grandma, she can't walk today, her workup's unremarkable, but she can't walk. And maybe this is her chronic illness is kind of progressing, there's really nothing acute, but we also can't send them home. That would be my guess, would be a frustrating admission. But I'd like for you to speak to that a little bit too.
Shout out to the grandmas. Yeah, for sure. No, it's true. So our carrots and sticks influence this as much as our ability to actually feel like we've had a meaningful contribution to this person's health. And I think there has to be an acknowledged reality. And some people would agree with me in my group, and some people would disagree with me in the group, that every job has its good parts and its bad parts. One of the bad parts is admitting grandma or grandpa because they're just tired and they don't have their usual spunk.
Yeah.
And they didn't look at the visiting family member from out of town the right way on Christmas Eve.
Yeah.
And so they got concerned and brought him in. Right.
Mm-hmm.
I think some people would just say that's just part of the job. Some people would say that's not a good use of our resources. Why are you bringing them in? Our system has gaps. Our system has pitfalls. It has chasms. And I think this is one of them, where this is the admission that probably drives us crazy, because the expectation, I think, doesn't often meet the reality. The family or patient may expect that we're going to have some meaningful outcomes, some step function improvement in this patient. That may not be the case.
Right.
We end up in these cases not being able to justify, truthfully, an inpatient diagnosis.
Yep.
So what you're getting effectively is someone who's consuming length of stay days, consuming a hospital bed, consuming precious and finite medical resources with very little meaningful outcome for them in the hospital. And then the challenge becomes a placement issue, where the family doesn't realize that they're going to get a 5 or 6 figure bill from the hospital pre-adjustment. And that's any institution, not just ours. And then they're going to be told they have to pay for a placement situation somewhere. Thousands, it's a mortgage a month for some of these places, right?
Mm-hmm.
Just to house your family member and have the support you need. And I think that creates that it can lead to a lot of distrust from our patients, because it's, if we'd only known about these financial ramifications, if we only knew there were other ways to go about this, maybe we would have approached this differently. And so I think those are our most frustrating admissions. We feel like we add very little value. We feel like we cost the patient and the families a lot of money. And we feel like we consume hospital resources on the terms of lengths of stay, hospital beds, which are our metrics for being seen as good hospitalists, right? So it kind of hits us in all three directions. It's a gut punch. But I think we have within our group debate about, is this just part of the job, or is this something you I hate to use the word fight, but you push back on the ER on. And I think something that would be helpful for us to know is what systems are in place within the emergency department and in what hours where these people could potentially be discharged directly after a PT or OT evaluation or after a financial assessment with the case manager. I don't think we have good line of sight on that. So what resources do exist that you guys have that you're actually making inroads to minimize these admissions? I think we'd love to hear that.
Yeah, I think if it's a weekday and it's early in the day, social work is really good at finding a solution for these people. They're good about talking to the family and saying, hey, it's going to cost this amount to get them placed, and sometimes they can do it quickly from the ER if it's during business hours, really, is my understanding, is where we can get the PT evaluation done quickly, and then social work. If it's after banker's hours, it's pretty difficult to do any of that.
What does that look like, though? Like, what is that like? Let's say grandma, and she came in, and Adam, you've got her in care unit 3 or 4. What is the it's floating,
sorry, that
floating
one
mics. Wardrobe malfunction.
Experienced. Start ripping my pasties off next. All right. Yeah, it's good. Yeah.
So what does that work process look like for you?
I would I would go as far as, this is going to sound a little ignorant, and I'm going to be blatantly honest about it. I don't think any of us really know what the hell social work's magic is. That's not something we're savvy to either. I couldn't reiterate to you what social work did in detail when they came down for a consult on a patient I'm trying to place directly from the ER at 3:30 on a Tuesday. I simply call for help. It's not something we're savvy to.
Yeah.
Who'd you call? How'd you work? Was that an insurance thing? Was that through their primary care doctor? Do you have resources in the community where you called 3 centers around here? I truly don't know. We are not savvy to the details of how social work and case management do what they do. We simply know that they're there, and that is a huge help. I would also say that I guess I couldn't speak for the rest of our group, but I would assume I'm not the only one, obviously. I would venture that most of us, and I know myself, I guess I'm only speaking for myself, but it can't just be me. We go to the extent of attempting to avoid admissions such as that. Mm-hmm. Some people, it may be simply because they're nervous about the interaction with the internal medicine doctor. Well, you know what? That's good enough. It ought to make you think, can I solve this problem down here? That's fine. But beyond that, more importantly, because we all know, even though the ER is the least savvy in the knowledge of numbers, they do not want us to know about costs because we take all comers. So we're not taught about insurance costs and other things, but we all know how broke the system is and how much things cost. The answer is simply a lot, and that's good enough to do your best by people. Right, we all know the stories of people going bankrupt from hospital bills, and almost every time the headline reads ER bill to start. So we know these things. We try to avoid these. During our business hours, and sometimes after, the days and nights where we have social work on call till 10 or 11 o'clock, we'll still call them, knowing that they're going to say, at this hour, there's nothing we can do. Okay, so be it, but we get them involved early. We call social work, we call case management, we oftentimes put in the order for PT up front going, I don't think this patient's going to walk at the end of this, and I don't think I'm going to have an admitting diagnosis other than they can no longer care for him at home, and this family's clearly telling me I'm not taking him home. Okay, so we get put in that corner often, and we try and call the cavalry about it up front. What they do is uncertain to us until they call us back, oftentimes several hours later, and say, this is someone we could probably get out tomorrow morning, going to need an obs admit. This is someone who's going to take the 2 midnight rule because of X, Y, or Z billing that we don't understand, but they tell us how it works. Mm-hmm. This is someone who I may be able to place at 9 o'clock on a Tuesday. By 1 o'clock this afternoon, I called this particular facility. They're available. They need the PTO eval, and if they fail with flying colors, which you tell us they will, that's where they can go. Okay, I'll hold them on obs here in the ER during that time. We try to do that for a lot of patients, to be honest. And we make a lot of progress there that the hospitalists will probably never know about because it's overshadowed by how many we can't make progress today from the ER. And our metrics that are out of our hands are pretty tight. I'm not going to give you a number, 2 hours, 4 hours, 6 hours in the ER. The answer is, how long are you guys planning on tying up this ER bed?
Less is better.
Less is better. What are you doing? This patient's been here 4.5 hours. You talk to social work and PT. Do you have an answer yet? Admin wants to know why they're still tying up an ER bed. And I'm like, frick, I guess it's time we got to talk to the hospital. So I'm not making progress. Help.
And those are the unfortunate ones where I use the verbiage, I have to sell this, because we all know these are the hard ones.
That's probably what you mean.
I know it's hard on the hospital because they're going to really struggle to get this patient dispositioned, find them placement. They're going to be there for longer, and there's nothing we're fixing. There's not an acute medical problem that anyone's solving.
The contribution you want to feel to their care that we know is not going to be there wasn't there for us either.
And it can be recursive then to you guys too, because then we have people up in the beds that, despite your best efforts, had to come in because they needed that obs stay, they needed that midnight. And by the way, I'd like to come back to that just because there's some very unfortunate language around that concept. But what comes back to hit you in boomerangs is now we're boarding 5 patients.
Now you're boarding in
two and one, right? And then we're having to round on patients in those ER care units, and like we all know, these dominoes just back up.
They do. And I would also say this: I know for one, and I can't be the only one. I preface that to people for y'all's sake, for sure. And my NPs and PAs that have worked with me will hear this at least once a shift. So, family is telling us that they cannot take them home. Patient is insistent that they cannot walk. Let's just go with that story. I feel like I'm about to uncover nothing other than progression of age and underlying disease. One of us, usually myself, will take the responsibility of going in and saying the hard words up front. So today, if I uncover nothing in the next 2 hours in your ER workup, and you tell me you can't take care of this individual at home anymore, and you tell me you can't care for you anymore, you understand that the last option is nursing home or care facility versus home resources like PTOT and nursing, which I can put in a home order for and probably get someone there in the next 24 hours to try and help. But big picture, you come in these doors, the thought is, I can no longer live independently at home. You understand that, right? And some people freak out. Oh, what? Well, I'm not going to a rehab. Okay, then you're going home, whether you can walk or not. You need to be able to tell me you understand. I'm going to send you home. You're going to talk to primary care. They're going to try and arrange resources or placement if needed over the next week or 2 or 3. Your family's going to have to go out in the community and start doing some homework. I'm going to put in a home health cert to try and get a PT or an OT or a nurse or all 3 at your home in the next 24 to 48 hours. I'm going to do these things. They may or may not all pan out quickly, but we're going home. Because you have to look me in the eye and tell me before I call a hospitalist who's busy as all get out at this shop, just like I am, you understand we're heading towards placement somewhere, not your home anymore.
I think that's so
and
helpful
I make them
to hear.
vocalize it.
Well, and I think
that's my responsibility.
It's more the
up front,
exception than the rule that social work and PT can bail us out. Sometimes PT goes in there and they're like, I walked them. They're at their baseline. They can use a walker just fine, despite the story that they can't walk. And we're like, okay, great. They're at their baseline. That makes this much easier. And then social work too. Sometimes in the span of 2 hours, they're like, yeah, we can get them in this rehab facility. Their insurance meshes really well with this infrastructure. And, you know, they're on obs for 2 hours in the ER and they have they're getting transferred. They're still sitting in the ER for hours longer than we prefer, but they're transported via EMS to a rehab facility.
And social work's eminently helpful, too, for resources. They'll come to the bedside just like you guys will and say, here's all your options, backing us up. And oftentimes that'll avoid it.
And they're helpful because I've had a lot of conversations with them where they will say, like, this is really something the family has to do. You know, this is not going to be easier because they are admitted to the hospital.
Yeah.
This is still an out-of-pocket expense. This is not going to be covered by insurance, and family needs to be making these phone calls. And sometimes it's nice to know that an admission will do that for them maybe and make some of these phone calls. But at the end of the day, this is not cheaper to admit them. It's not going to change anything. They're just going to be sitting in a hospital bed as opposed to at home. Doing the same amount of work for no cheaper cost out of pocket to the family.
And occasionally, and maybe not infrequently, I think as ER docs, we could push a little harder, to be honest, to the patient. To the patient, meaning I think sometimes there's a mindset when you're busy. Patient said they can't walk. Hey, you need to admit them. I give a little pushback
trust your patients.
To the patient.
You're like, okay.
Well, the longer you work in this job, the less you trust your patients.
Well, here's the thing,
without proof. So I'll call PT.
Trust but
or
verify.
I'll walk in the room and I'll say, I'm going to need you to give it your best because this is where this is going. A little push oftentimes makes grandma realize, I don't want to do this right now. Makes family go, oh, I guess she was just tired. Whatever. And oftentimes they fail safely in our hands, and we go, all right, so be it. But a little push goes a long way. When we get to the point where we're overwhelmed and busy and go, hey, patient states they can't walk, might as well just put in the admission order now. We should do a better job of proving that some way to be true, because there are a lot of tired old people in the community these days that don't need a hospital admission. And we learn a lot from talking to y'all, too. These could be some of the consult calls. Well, I didn't know the failures, the things we can't accomplish during admission sometimes until a hospitalist said to me, I really have nothing to offer because of X, Y, and Z. Oh, all right. Well, that's good to know. That's good to